This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander from Wake Forest University, and today I'm here with Dave Greer, Professor and Chair of Neurology at Boston University and Boston Medical Center. He's joining us today to talk about the updated guidelines for brain death criteria in adults and pediatric patients, which was just published in Neurology this month. So, Dave, thanks so much for joining us.
Pleasure to be here. Thanks for having me.
I wanted to make sure that we went through all of the updates to the guidelines and everything, but can you just start by summarizing what are the main changes and updates from the previous guidelines?
This guideline is, I think, very exciting, and it's been years in the making. And it finally integrates guidance for adults and children into a single guideline and provides a comprehensive and really practical way to evaluate somebody who sustained a catastrophic brain injury to determine if they have brain death or not. It updates on the prerequisites for brain death determination, the examination, the examiners, how many are required, and what kind of qualifications they should have. It updates on the best way to do apnea testing, both meticulously but also safely. And it provides updates on ancillary testing also. I'd strongly encourage your listeners to look at our article that was published in Neurology: Clinical Practice, where Matt Kirshen and Ariane Lewis and I really outline the differences between the old and the new guidelines, really to make it easy for people, because otherwise you're looking back and forth between the two guidelines, and we want you to understand exactly what's different now. So that's hopefully a good resource for you. We also provide new guidance on what to do in the setting of a hypothermic patient, whether it's iatrogenic or environmental. Patients with a primary infratentorial injury or brainstem hemorrhage, for example, patients with pregnancy and possible brain death, patients on ECMO, and patients who have diabetes insipidus or who do not, and what to do in those circumstances. So hopefully we provided a lot of good practical guidance and been evidence-based or consensus-based as the case required.
Yeah, thanks so much for that review and pointing us toward that additional resource. I noticed, as somebody who reads EEGs, that EEG was removed as one of the possible ancillary tests. Do you want to talk about why that decision was made?
The issue with EEG is twofold. One is that it doesn't measure brainstem activity at all. And so it's not a great test to use as an ancillary test, and really never has been. In the early going, when this first came out as an ancillary test, it was meant to be used in conjunction with evoked potentials, which could, to at least some degree, assess brainstem integrity. But an EEG, scalp EEG itself, would not measure anything in terms of electrical activity in the brainstem or viability. And so it's not good from that standpoint. And it's also not good because in the ICU setting, as you know, there's a lot of electromagnetic interference, and you can get little blips, which you don't know if it's coming from the environment or it's coming from the patient. So you can have false positives and false negatives with EEG, and we felt that it was really time to do away with this as an ancillary test.
Yeah, I think that makes a lot of sense. And I know for the pediatric patients, having the two providers do an exam, that's something that still stands, right? But are there any changes to who those providers can be or anything like that?
Yeah, and it was really important to the pediatric community, and we very much respect that there remain two examinations and two apnea tests. And so that was really a crucial thing for us to include. And we established that there needed to be still an intervening waiting period between the two examinations, but it was 12 hours across the board, regardless of the patient's age, assuming that they were of an appropriate age to be determined to be brain dead in the first place. In terms of the qualifications of the examiners, we really want people who are expert in this and are doing it a lot. And so this could include neonatologists, it could include pediatric intensivists, it could include pediatric neurologists. Any of the above would be appropriate, provided that they had the expertise and the training. And the Neurocritical Care Society has really tried to put forth a really great online training course to help people, both adults and pediatricians, to do this correctly. There wasn't previously a course for this online, and now there's a way to get trained and certified. And hopefully people can do in-person courses also, such as put on at NCS, but also at the AAN meeting every year. We put on a course that includes guidance for pediatricians too. So hopefully that's helpful for people.
Can you talk about, too, what are some of the differences between diagnosing brain death in adult patients and pediatric patients? I know you mentioned there's an age cutoff, if you could talk about that as well.
Yeah, so we don't want anybody being declared brain dead at less than 37 weeks gestational age because we really don't know when somebody is in a permanent state younger than that age. So that's the cutoff. There used to be different age groups that had different rules with the prior pediatric guidelines. And as I said, that's really been changed for the new guidelines where it's much more straightforward, I think. There are obviously differences between adults and children. One very specific one is blood pressure. We wouldn't require a child to have at least an arterial pressure of 75 like we do in adults. So we carve out the difference for blood pressure that it has to be greater than the fifth percentile for age for both SBP and the mean arterial pressure as well. We emphasize that in children who are less than 2 years old, they often have unfused sutures and open fontanelles. So that changes the intracranial physiology, and the patient may take longer to determine whether they've had a clear, irreversible, or permanent injury. So we really want people to err on the side of caution. As I mentioned earlier, 2 examinations and 2 apnea tests in children. In adults, we emphasize at the very least 1 examination, but we say that 2 examinations will provide greater certainty. So we really encourage that. But only 1 apnea test in adults, and that's always been the norm. And then the final difference, I would say, is the use of transcranial Doppler. This has not been validated in children, so it's only an acceptable ancillary test in adults until it does get evaluated thoroughly in children. So those are some of the major differences between the two.
And correct me if I'm wrong, but one of the major reasons for providing the update was that there were some discrepancies in brain death declaration that were varying by different locations and different providers. They were being done in different ways. Are there items, even with the update, that we would still expect to vary based on location?
We recommend, first and foremost, that clinicians follow their state and their local hospitals' legal requirements and processes. And some hospitals may choose to have 1 versus 2 examinations in adults, but in pediatric patients, all states should require 2 examinations and 2 apnea tests because that is really the standard. I think that that's going to be one of the differences moving forward, is that still some states may require 1 versus 2 examinations. Otherwise, there shouldn't be a lot of variability in brain death. You shouldn't be dead in Wyoming, but not in Virginia. And so the prerequisites, the examination, the apnea testing, the ancillary testing, the documentation, all of those things really should be pretty standard. And we tried to provide guidance in terms of checklists and very rote information for people so that they could really just follow the guidelines as we put forth from the AAN. We tried to make it as simple as possible. So hopefully people will find it that way.
We appreciate those efforts to make it as standardized and easy to follow as possible, like you've done with these guidelines. So you've updated, adding the information that we know about targeted temperature management, ECMO, pregnancy, as you stated. But what questions still remain?
So we have a lot of questions that remain. And at this point, I'll refer you to the World Brain Death Project that we published in JAMA in 2020, where we put forth over 50 research questions that need to be answered. Some of them are regarding the use of CT angiography. I know that people really want to use that, but it hasn't been validated against a gold standard blood flow study and needs to be. So we need prospective studies that look at that and ensure that there's a very minuscule, if any, false positive rate, or at least that the technique has been figured out so that you can eliminate false positives with CT angiography. But that's just one of many, many questions that we raised. So we've started up a big national database running out of Boston University and Boston Medical Center, where we have thousands of patients with brain death. This is all retrospective at this point, but it'll also have prospective arms. But this is how you answer these questions that remain. Unless you put lots of centers together and really collect the data and look at it very systematically, you can't answer these questions. And I should mention that my friend Matt Kirshen at Children's Hospital of Pennsylvania, they also have started the pediatric database, likewise, to try to answer these questions. So we are not saying that this is the end for brain death. We expect the field to grow and to mature. And so by the time we do new guidelines in the next 10, 15 years, hopefully we'll have really good data from these studies to be able to understand how to do this perfectly every time.
And likely some new technology to add into the mix by then as well. So before we go, is there anything else you want to add?
Well, I think the most important message from the guidelines is to err on the side of conservative, meaning that if you have any doubt about the permanence of the patient's condition, do not declare brain death. Don't ever be in a rush to declare brain death in a patient. Make sure that you're allowing for all the prerequisites to be met. And if you think that there's any potential confounding, you really have to either wait that out or get a tried and true ancillary test to make sure. But we don't want people, for example, just getting a spec study to let's see if they're brain dead. And unfortunately, we see that a lot. And that's really very faulty practice. We should be absolutely sure, even when you know that you're going to get an ancillary test, make sure that you're testing the clinical exam to the fullest extent possible. Because if you find any signs of brain function, the patient is not dead. And you shouldn't be getting an ancillary test in the first place. So I think those are a couple of really important messages that I would share at the end here.
Excellent points. Thank you for sharing that. So again, I've been speaking today with Dave Greer about the updated guidelines for adult and pediatric brain death. You can find the full report in this month's issue of Neurology. There's also a nice summary in Neurology Clinical Practice. And for even more information, the topic is also covered in the October 19th issue of Neurology Today. Dave, thanks so much for joining us.
Thank you for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.